Hello, everyone. Greetings. This is Eric Glazer, and welcome to another live recording of Bright Spots in Healthcare produced by Shared Purpose Connect. We bring leaders like the ones you see in front of you to not only inform you, our audience, but also unearth bright spots, successes at health plans and hospitals and other healthcare organizations around the country. Our goal is to identify as many bright spots as possible so that you can determine if the ideas shared during this episode can be applied at your organization. We believe this approach of finding a bright spot and cloning it is the most effective strategy to improve healthcare in our lifetime. Now, we are around the holidays. Even if you're listening to this after the new year, if you're in the giving mood, I would like you to take a moment right now to go to your favorite podcast app, if you haven't already, and subscribe to Bright Spots in Healthcare. This is a way to get downloaded to your device all the great insights and advice from your peers in the industry that come on the show each week that could help inform you on how to do a better job supporting your members, challenge your thinking, support your thinking. So I ask you the favor of doing that and maybe putting in a comment and a rating. This allows more of your peers to find the show and tap into all the great information that our great guests share each and every week. So I thank you. Happy holidays to all of you, and I thank you in advance for giving me this small little favor. You're all Santa to me. Our topic today is a super important one and top of mind for everyone in the industry. It's about lifestyle modification strategies, things that are working to support those living with obesity and diabetes. And we have an incredible panel put together for you. The theme is Make New Friends and Keep the Old. I'm going to first introduce one of the new friends. We're new to the show, Dr. Katherine Saunders. She is an obesity expert. She's also the co-founder, and executive vice president of a company called Intellihealth. So, Dr. Saunders, welcome to the show.
Thank you for having me. I'm excited to be here.
I know I have some of my favorite returnees coming onto Bright Spots in Healthcare. Bright and early from the West Coast is Angie Kalousek. Ebrahimi. She is the Senior Director of Lifestyle Medicine at Blue Shield of California, and one of those whose last name scares me the most to say. So welcome back to the show, Angie. I'm super excited to have you here. Good seeing you. We also have Driscoll, who is the founder and CEO of NourishedRX, one of the partners to Bright Spots in Healthcare. I'll tell you a bit about them in a moment. And Dr. Timothy Law, Chief Medical Officer at Highmark Health, someone who has treated astronauts in the space station as well as animals in Pennsylvania. We got to do that one-on-one deep dive on you, Tim, one of these days. I know we've been talking about it. So very interesting fellow there. Thank you all for joining us. As usual, I'm going to save time and bypass reading all of your full bios. We're going to post a link for those of you watching live. It'll be right in your chat, a link to all of their bios so you can get a taste of some of the expertise you're about to benefit from. And if you are listening on your podcast app, we'll put it right in the show description so you can click on it while you're walking, while you're talking, while you're on your airplane, not while you're driving. Don't look at it while you're driving. Our partner, like I said, for today's episode is NourishedRX. We're super excited to be partnering with them again around a really important topic like this. If you haven't heard of NourishedRX, they partner with healthcare organizations nationally to nourish their most vulnerable populations, building healthy relationships and supporting health equity. And they deliver this very highly personalized, culturally relevant meal program and groceries to members, along with wraparound whole health support and nutrition education. I'm going to tell you a little bit more about them later on during the episode, but if you want to check them out right now, if I've piqued your interest, you could type in nourishedrx.com to learn a little bit more about the organization. All right, let's get started. We have a lot to cover. If you do want to help co-moderate and you're listening live, you could type into the Q&A module. Gene Ware, our producer, will be keeping an eye on those and be sending me questions to integrate into the conversation. PSA, though, and there'll be a couple of PSAs today, but the first one is we really are tight on time, so I'll do my best. But we have a lot of planned questions, some of them that have been inspired by the questions that all of you submitted prior to registration or during registration, and we've tried to make sure we're covering most of everything. So before we start talking specifically about GLP-1s and medical medication interventions and combining therapies with lifestyle modification, let's first start talking about the foundational elements that are contributing to the problem and how health organizations should be thinking about these problems, especially as it relates to the diseases of obesity and diabetes. So I'm going to bring in first Lauren Driscoll, founder and CEO of NourishedRX. Lauren, how do social drivers play into a lifestyle modification strategy? Maybe provide an example of how a plan is successfully incorporating a social driver strategy into the overall population health strategy, targeting subpopulations of those living with diabetes.
Sure, happy to. Thank you, Eric. First of all, it's just wonderful to be here with you, Angie, Tim, and Katherine. So to answer your question, I mean, I think it's obvious to all of us on this panel and all the people watching at this point that our zip code has much more impact on our health than our genetic code or the healthcare we receive. And indeed, the literature is clear that the likelihood of both diabetes and obesity is highly correlated to food and nutrition insecurity, which cuts across nutrition insecurity, really cuts across the three broad buckets of social drivers of health, which are physical environment, health behavior, and socioeconomic factors. And so it's really important to think about all three of those when you're trying to address diabetes and obesity, given nutrition and diet is really a root cause. And I'd go one step further than those three buckets and say that we also really need to consider sociocultural factors. I mean, it's just human nature to be nostalgically attached to the diet that one has grown up with. So I would say, a key sort of step one in terms of administering programs that are addressing the social drivers of health as a root cause of diabetes and obesity is recognizing the importance of cultural concordance when you're really trying to support behavior change, dietary behavior change. Secondly, what we are seeing as particularly successful is when nutrition is part of an integrated solution that can really engage whole person health. So not narrowly focused on diet and nutrition, but really as part of a whole person intervention. And so as an example, you asked for an example, we have a program that we've been running in the Midwest with a health plan, and the program is targeting people who are food insecure, have screened positive for risk of food insecurity, and they also are diagnosed with uncontrolled diabetes, defined in this case as a A1C of 8 or higher. And many of them, not surprisingly, also have obesity as a comorbidity. And so it really is a whole health program that has an emphasis on diet and healthy food. And the secret here really is that if you can provide sort of personalized, culturally concordant food that people like, then you can really build connection with people. And then that is a real door opener for broader support, whether that be need for different medication therapy or transportation to a doctor's office or referral to a specialist. And so by taking this integrated whole health approach, we've seen results that have been really encouraging. And we're continuing on with this program, so the results will continue to mount. But to date, we've worked with a cohort of about 75 patients. And we've come up with, our partner has come up with some statistically significant results that I'm happy to share. The median A1C across the group was about 1.4%. And it's important to call out that this has been over a 14-week period of time, so a pretty short turnaround. Additionally, our partner has been tracking outcomes over time. So looking at, 3 months post the intervention, 6 months post the intervention, 9 months. And while not enough time has passed yet for us to, have the full results, we are seeing very encouraging results that the A1Cs are continuing to go down. So what we've found by taking this sort of integrated whole health, but with an emphasis on nutrition approach, is that not only are we helping people during the period of time that we've been providing food, but we are also really changing the trajectory of their diet and health over time. And then I just one last call out about this particular program, and really the reason why I chose it to talk about today is that we are controlling for those who had major medication changes during the intervention with an anti-diabetic medication, including some GLP-1s. And what we found is that both those with and without the major medication change have still shown a statistically significant drop in the A1Cs, and are factored into that average of close to 1.4 that I mentioned earlier. And finally, just in terms of the good results that we're seeing, our partner has looked at quality adjusted life years, and they've translated that into lifetime medical savings per individual. And we are looking at over 200 or right around 250,000 per individual. So again, just a great example of the importance of looking at sociocultural factors, and really taking a comprehensive approach.
Yeah, I like that. Since you teased it, and I've seen your team sent me like a high level summary of those study results, and a little bit, what I really liked about it was they outlined the key infrastructural kind of components that allowed you to implement that and allowed that health plan to implement the program. If you want a copy of that, folks, because I know Lauren just teased it, I'll send it to you personally at the end of the show. Gene, why don't you just throw up something, and people that want it, we'll send a quick email out at the end of the show with a copy of that. I want to gain a physician's perspective. So I'm going to bring in Dr. Katherine Saunders. She's the EVP and co-founder of Intellihealth. Dr. Saunders, can you tell us a little bit about quickly your clinical background? Because I know you focus on obesity, but then maybe provide some guidance on what should go into a nutritional strategy for those ultimately we're trying to support in making modifications to both their lifestyle and their diet.
Sure. Yeah, thank you so much for having me. So excited to be here with this amazing panel. My background is that I'm an internal medicine physician. I subspecialized in obesity medicine. I was the first fellow at Cornell, one of the first in the country. This was about a decade ago. And then I joined the faculty practice at the Weight Center at Weill Cornell Medicine, where I practiced for several years before I co-founded Intellihealth with my mentor, Dr. Lou Aroney, and my husband, Sloan Saunders, to really scale and democratize access to the kind of very high-level comprehensive medical obesity treatment that we deliver. And we're focused on the employer space right now. But we also, can see patients who find us otherwise. So our medical practice is called Flight Medical. But I love everything that Lauren said. Totally agree with, a comprehensive approach. Really personalizing everything. So when we evaluate our patients, we spend a lot of time asking tons of questions and looking at tons of labs for the purpose of really identifying every single contributor to obesity. So everything that's pushing their weight up and everything that's been a barrier to weight loss, to figure out how we can address everything. And diet is a huge, huge, huge part of that. And behavioral factors surrounding diet are a huge part of that. And so, if you take a look at data, there's so many studies looking at low fat versus low carb and specific diets looking at macronutrients. But, when it really comes down to it, the best diet for anybody is the diet that will not feel like a diet and the diet that will be sustainable. I tell all of my patients that I never want them to feel like they're on a diet. I want to work with them very closely, or have my dietitians also, play a big part in helping them to figure out what's doable, what's a deal breaker, what fits in with their life, so that we come to a place where they are following an eating pattern that is really nutritious and where the food is really filling, and we try to avoid juice and soda and ultra processed food, and, good nutrition is good nutrition. That is a quote from one of our dietitians who, has been doing this for so long and really makes a big point of, fitting dietary strategy into somebody's lifestyle. It has to work for the individual. There's no one size fits all approach here. It's time consuming to get to know patients and figure out everything that's going on, and then keep supporting them in what they're willing to do and what doesn't feel too onerous, doesn't feel too restrictive, and what they can continue doing long term.
That's super helpful and interesting. And now that we have, I love sort of, we've got like the food strategy perspective, we've got the deep clinical perspective. Let's bring in the health plan. Cheers from all parts of the arena.
I don't know. I don't hear them.
Well, they're all, you think about pushing over those. So Angie, Angie Kalousek, Ebrahimi is the Senior Director of Lifestyle Medicine at Blue Shield of California, if you're joining late. So Angie, let's talk about how Blue Shield of California, small little known health plan out there on the West Coast, how are you supporting everything, so the concepts that you heard Lauren and Katherine speak to?
Yeah, and I absolutely love what you both said, and it warms my heart sort of to see this in clinical practice and sort of out in the community. And we are also trying very desperately to figure out ways to scale this. And the way that we have done that is we created a platform that is called Wellvolution, and it hosts sort of an array of different digital solutions that people can engage in at no cost to them, that can help support them in a whole number of things. And Lauren, I love what you said about a whole person health approach, because that's what we're trying to do with Wellvolution. So we have programs that support people who have cardiometabolic conditions such as type 2 diabetes and hypertension. We also have programs that support obesity management, weight loss, diabetes prevention. And we have a subset of our programs that are dedicated to mental and behavioral health, emotional resilience, stress reduction, sleep, all of which we know contributes to chronic conditions. So the way that people access Wellvolution is they go into the platform and they take a short quiz. So I know that we're going to get to the point where we're doing labs for all of our members, and actually some of the providers in our networks do those, but kind of as a intro to those programs, we ask a number of questions. What are you trying to work on? What is your number one goal? How do you want to work on this? Do you like having an individual coach? Do you want to do a more Mediterranean diet or a keto diet? Like, what are the things, as you said, Katherine, that will work for you and that you can sustain? And then we match them with one of the wonderful programs in our network, and kind of off they go. We're really excited about the approach of kind of lifestyle first, especially when it comes to some of these conditions like obesity. We know there is this huge craze right now around GLP-1s, and for some people, they are the right strategy. However, we also know that the adherence to the medication is so-so, right? It's about 50% after a year. And some studies are showing that if people go off the medication, they're gaining about 2/3 of their weight back. So having a lifestyle program that allows you to develop and deepen habits, either before or at least as an adjunct to those types of medications, can be kind of the linchpin to success or failure. And so we're really excited to have this for our members.
I love that. I'll also give an unsolicited kind of like book recommendations to people listening. So as someone who has gone through a little bit of his own lifestyle alteration since maybe July, and continues to hopefully have changed or working towards a permanent change in my lifestyle, there's 2 books that I think if everyone read, they could at least understand what your populations are up against and what needs to happen. One's called Atomic Habits by James Clear, which is just a simply great book. And the other, which is also a great book, and also a little bit more scientifically focused, one called Tiny Habits by BJ Fogg. And you mentioned habits and tiny habits. And so it strikes me that, I'm going to bring back in Lauren to talk a little bit about this. Like, how should health plans, Lauren, with everyone you're working with, think about lifestyle modification programs? You heard just what Angie's doing and trying to fit in lifestyle change. Katherine provided that advice. It can't feel like a diet. How are we incorporating like nudges a little at a time, that approach to a lifestyle modification program, and what should other organizations be thinking about incorporating around that methodology into their strategy?
Sure. Well, again, I think it's really important to think about it holistically. And so we really think about it in three different dimensions. The first is really on a micro level, which is behavior change. The second is about environment. So these sort of align with the buckets of social determinants of health. So the second is about environment and exposure, which really dictates familiarity and access to healthy food and understanding of nutrition. And then the third is more macro, payment and policy. Wouldn't it be ideal if sort of the macroeconomic incentives in our country supported nutritious food being prevalent versus high caloric, high glycemic foods? But obviously that one's more in the realm of policy. But I'll talk really about the first two, the behavior change and environment and exposure. In terms of behavior change, we just know, and this is aligned with the work you were talking about by Clear and Fogg, Eric, we know that a key to supporting behavioral changes is really nudging sort of micro changes. And that's important because we really want people to experience even tiny successes, which then give them a sense of self-efficacy, which is so key for the lasting change and trajectory. And we particularly, there's a lot of excellent evidence base out there, including the work that you referenced, Eric. We particularly rely on motivational interviewing, harm reduction theory, which is key in terms of a little bit at a time is okay. And the Prochaska stages of change, making sure you're meeting someone with respect to their readiness for change. And then with respect to the second dimension, environment and exposure and reasonable access to nutrition, we really think it's important to make a point of providing home delivered food. And again, in the interest of, supporting those micro changes, we tend to offer the food or supply the food in a progressive manner. And what I mean by that is we'll start with prepared meals that are culturally concordant and aligned with someone's taste, even though there may be, a larger proportion of vegetables than they're used to getting. It's a micro step. And then we'll graduate to groceries with meal prep guidance and, to really support that next step of actually managing one's diet and nutrition. And then finally, because we're usually a time limited intervention, we will support people in leveraging community-based resources and benefits like SNAP or WIC so that they can continue, the behaviors that they've actually, come to be comfortable with.
So with that in mind, I'm going to bring in now Dr. Tim Law, who's been sitting patiently, waiting in the wings. So as a reminder, it's been a long time since I first introduced Tim, about 20 minutes. He's the Chief Medical Officer of Highmark Health out in Pennsylvania. So Tim, how is Highmark now taking digital therapeutics and supporting a lot of the things that Lauren just mentioned around lifestyle modification? You're on mute, Tim, but yeah, I iced you. So like, there's no way like.
Yeah. I was going to say, thank you. You get the award for keeping me the quietest, the longest of anyone ever. So Anyway, thanks for having me on this panel. Great bunch of information here, some really genius ideas. But take a step back and listen to all the great things that were said and the knowledge that's out there from industry, both on the payer side, provider side, and look how hard it is still to make a difference in it and make any kind of impact. And so I'm just going to get a quick soapbox here on the word change. Nobody seems to like change. We do change management in our industry and people fret about it. We do change our diet and people fret about it. I like to think of it as more adaptation. It's like allergy shots. We don't change people's immune system. We help it adapt to its surroundings, and I think that's kind of what we have to do in the lifestyle modification and nutrition bucket. So I know at least here in the Midwest, it seems people don't like the word change very well. So having said that, Highmark is really deep into the digital therapeutic space. We were kind of the first company in the United States to actually have medical policy and coverage for digital therapeutics, and we still are focused on that. We had meetings yesterday looking at some new products. We're looking at digital therapeutics in two ways. One is our own internal My Highmark app to help with our employees and those that have Highmark Blue Cross Blue Shield insurance to be able to go on there and talk to coaches, interact with various mechanisms to keep food diaries, talking about the keto, the Mediterranean stuff that Angie had mentioned earlier, all those type of things to give support to people to help them have a valid place to go for information that they can trust and that we know that is good information to have out there. Because as you know, as much great information is on this panel today, there's just as much quote misinformation out there talking about the various quote diets that are out there. To Katherine's point, it should be a new way of eating, not a fad diet that you're going to do for 2 weeks. It has to be something that is sustainable, accessible, and it just becomes part of your structure. I have a lot of farmers as a rural community here in Kentucky where I do my practice, and to go in there and tell them you have to change and go on a diet, you will get kicked off the farm before you can even have your first piece of steak with them. So anyway, all these ideas are great, and it works across all factions of life, from those zip codes that seem to be doomed to failure because of food deserts and that kind of thing, to those that are sitting among the most plentiful areas of food there are. You still have to make choices, and I think that's up to us and to move on a macro level to have those choices help make them a little easier for everybody. So the digital side is huge. There's all kind of apps out there. We're trying to go through those. We're on the early payer feedback program with the FDA to look at new apps and digital technology that's coming out and make sure that we're getting the right things into the hands of our members.
Okay, so let's transition, Tim, to the white elephant in the room here, and let's address GLP-1s and medication management head on here. How are you guys thinking about GLP-1s? How are you supporting those living with diabetes and obesity, but also keeping in mind that you got to make the dollars balance?
Yeah, it's obviously, I'm sure for everyone on this call and those watching and listening, it's been front and center as a topic of discussion at both the executive leadership table as well as the kitchen table, probably. And so, when the board first asked me about these expensive medications that were to help people lose weight and fight diabetes, and we're saying how we're going to keep these from going haywire and putting them into everybody's hand, I remember just looking at them saying, when was the last time in the United States or anywhere in the world that we weren't interested in treating diabetes or obesity? The downstream cost of care and the detrimental effect both of those have on human life is astronomical. The cost is nothing compared to $1,200 or whatever it is a month for one of these shots. What we have to do, though, is like with any medicine, whether it's a diabetes medicine, a blood pressure medicine, or whatever, we have to use them intelligently and not in a box by themselves. And so, to Katherine's point and Angie's point, and Lauren's point, this has to be part of a whole lifestyle modification. I'm glad we're staying away from just the word diet and it's all lifestyle. It's about the right types of food, nutrition, to plagiarize your nutritionist words there, Katherine. Nutrition is good nutrition, and that holds true across the line. And, and Angie said earlier that after a year, 50% of the people weren't taking them anymore. Maybe that's because we're handing it out like candy, or maybe there's some handing it out like candy instead of along with the whole lifestyle approach to how to handle these two chronic diseases that are running rampant in spite of all this great information and knowledge that we have out there. And so, we're trying to look for new companies that, the telemarket and the telemedicine industry to say, are you just handing out the medicine, or are you also offering coaching and lifestyle coaching as far as how to eat, where to find your food, what kind of foods, is it processed, is it closer to the way nature put it in front of us, that kind of thing. And so I think all those combined are what's going to work. And then let's not forget, we haven't mentioned yet much about exercise, but if you talk about using GLPs that are having you lose weight, and maybe 40% of that weight is lean body mass, we're setting people up for failure. We're putting that Instagram filter on them, making it look like everything's good, when in fact behind the filter it's still the same old person. And if they've lost lean body mass, they're not going to be able to continue to burn calories and have a metabolism that's beneficial to them in the long run. And so that exercise part of this whole lifestyle modification has to be one of the spokes in that wheel that we have to keep attacking, I think.
Yeah, if you don't mind, Katherine, I'm going to bring you in for an impromptu and a follow-up. So just get a little bit of a quick little roundtable here. So Katherine, there's a question. So one, I would love you to react to what Tim just said. And also there's a question that I think just plays into, like, we know exercise plays a huge role in all this. Are there, and we've talked about nutrition already, are there other behavioral modifications that your organization's recommending? Would it be meditation, visualization, and other techniques?
Great question. And Tim, I love everything that you said as well. What we're seeing right now is just so much like robo-prescribing of GLP-1s without any infrastructure. And it's really, really, really problematic, because these are powerful medications that can't just be prescribed with no education and no support. It's just, setting people up for failure. So, going back to what I was talking about with diet, what we do is we do a very thorough evaluation. And this is, good medical obesity treatment, where you need to do a very thorough evaluation to figure out everything that's going on. Part of that is, what is their baseline diet? What is their baseline exercise? What are they willing to do? Are they, do they have a lifestyle that supports what they're doing or not? And then prescribing the medication that is the most appropriate if they're a good candidate for medical obesity treatment. There are other medications, not just GLP-1s, that are in our armamentarium. And, so many people forget about that because of all this GLP-1 hype. But GLP-1s are fabulous. We use them strategically in the appropriate patients, but we have many other options. So to answer your question, Eric, about exercise, that is a huge, huge part of our plan. So when we set up, a treatment plan with the patient, we explain how to use the medication, why they're using the medication, the fact that it needs to be long-term treatment because this is a chronic disease. And then we surround that with, dietary interventions to support what they're doing, exercise, exactly what you're saying, Tim, because if people are not exercising as they lose weight, about a third of what they're going to lose is muscle. And that is not a good situation for keeping the weight off, for overall health, for insulin resistance. So that is something that we reinforce. And then the other question, Eric, was about behavioral change. Yes, huge, huge, huge. I mean, when someone's on an anti-obesity medication and they're a good candidate and it's, a good situation, it really helps everything else fall into place. The idea is not to make this all onerous. It has to be, they feel less hungry. They're able to make better food choices because we're targeting the pathways that are dysregulated in obesity. And then it helps people to stay on track. In terms of behavioral change, we really talk about, how they're going to set themselves up for success long-term. It's really important that they understand that this has to be long-term treatment. It's really important that they're tracking, that they're weighing themselves, that they're doing things to really transition to the phase of weight maintenance, where it's much harder than weight loss. And in weight maintenance, you need to make sure that you don't just suddenly and significantly gain a tremendous amount of weight, which most people have in their weight histories. And, they've lost and gained a million times. But this time we want to make sure that we set them up to be weighing, to be tracking, to be thinking about this in a way that they know they're high risk for significant and very sudden weight regain. So weighing themselves is one of the most important behavioral modifications that we really, really, really reinforce.
Yeah, I like that. I mean, not that I'm the persona that necessarily everyone's talking about, but in my sort of lifestyle alteration program, that my trainer has me weighing in every day, which just has a mindset, like just keep an eye on what your behaviors impact are. So it totally resonates. I assume so. I want to the GLP-1s, and I want to get sort of Blue Shield California's perspective on this too now, but the medication management part of this, Katherine, and I guess Tim, I'd like you to chime in here, and the we'll call it the modification or adaptation part of this, when combined, I assume is creating incredibly accretive value. I mean, I know the jury's still going to be out, still all relatively new, but 1 + 1 probably equals 3. I'd love for you to comment on that. Maybe Tim, a couple of comments on that, and then I'll have Katherine jump in, and then we'll
Sure.
and our doctor about that.
Yeah, sorry. So as far as how that 1 + 1 equals to 3, we're looking at things. We're bringing into the food logs and all those kind of things that we kind of mentioned earlier to make sure that people are truly getting the full spectrum of treatment, not just the shot. Because we can't kid ourselves. You can either push back on things like that, or figure out how to incorporate them into a comprehensive plan, as Katherine mentioned, because there's more coming down the pike. GLP is not the end all be all. It's not the end game. It's just the next branch into this whole web of what's going to happen next. There's going to be orals coming through in the next year or two that are going to do similar, the same type of thing. And so we as an industry, if we're not ahead of the game, we aren't going to get to the people to that stage where that 1 + 1 equals 3, and it's going to be 1 + 1 ends up equals 0, because neither one of the ones are going to be well founded in any basis. So yeah, so I agree. I'm sure Katherine has some points there too.
Yeah, I think again, kind of going back to what we're seeing all over the place, kind of robo-prescribing of GLP-1s with no education and no support, that is not, quality medical obesity treatment. And obesity is a really complex, heterogeneous disease that needs to be personalized. So again, it's not all about GLP-1s. We have so many other tools. Everyone is just really fixated on GLP-1s right now because yes, they're very effective and, it's the newest thing, but, it's not just a one size fits all approach. But, as Tim was saying, if someone is just taking medication and doing nothing else, then, that's not a great situation. It really needs to be everything else falling into place. It's funny because these days, a lot of patients are like, oh, no, I don't need to see a dietitian. And everyone thinks that like dietitians are no longer necessary. And, we don't have to focus on lifestyle as much because our medications are so effective. But it's actually the opposite. When people are on these medications and they have a smaller appetite, you could totally get away with just eating garbage all the time, but you'll still lose weight. But if we're talking about health outcomes, and we don't want people having vitamin deficiencies, like dietitians are really important here to talk about, how to tolerate these medications, how to ensure that you're eating enough protein. It's almost like after bariatric surgery where, it's a different way of thinking about food because you're eating less. So you need to eat a good amount of protein. You need to have a nutritious way of eating. And then the exercise. I mean, I can't stress this enough. What's coming down the pipeline are medications that actually help preserve muscle mass as part of weight loss. And we're not there yet. We don't have them. They're still, early stage, but that's what everyone's talking about right now, because that would be really, really, really groundbreaking. Because we don't want a situation where people are losing all this weight and then, losing so much muscle mass. And as Tim said, that reduces, metabolic rate. And we need to really, boost that as much as we can. We need to, work on insulin sensitivity. So it has to be, as Tim said, an intelligent way of approaching all of this very comprehensively in a very personalized way.
And just to add to that, and Eric, please note, she mentioned protein and trying to get your protein in. That's a discussion Eric and I have quite frequently. But also, Katherine, in amongst all that, by doing this in a very deliberate way, I think we decrease some of the stress on the patients. Stress with all its cortisol levels and other anti-insulin and anti-diabetic kind of effects on the body is just huge. So watching a YouTube video on how to do a starvation diet and decrease your ghrelin so that you don't get hungry anymore is not the way to lose weight. Not even close. And so I think these big comprehensive plans, we all really have to be diligent, both on the provider side and the payer side, to make sure that the macroeconomics of it is out there, and the ability for providers like Katherine's group to be able to do that within the confines of people not A, having to go to the poorhouse to be able to get it done, and B, having proper techniques and input from diet, from nutritionists, et cetera.
Well said. I want to get into some examples now, and I also want to get into the big, the benefit design, which everyone's probably thinking about in the audience. So I'm gonna have Angie warming up like in the bullpen. I do want to. It was a perfect tee up around personalization. Katherine was talking about that, and that's a great way of me just taking a quick pause to let everyone know a little bit more about our partner for today's episode, NourishedRX. Bright Spots in Health, we've been doing this show for over 10 years now, and it's so important that we find these incredible partners to support the show. And it's not about funding. The show has to have funds, but it's about the expertise and the subject matter expertise. And so when you look into an organization like NourishedRX, they're a leading digital health and nutrition company that has all kinds of wealth of information and expertise, and they specialize in personalized, comprehensive solutions for consumers and your health plan members who are living with diabetes, obesity, and other diet-related conditions. And here's a little bit how they do it. They recognize food's healing and connection power, and they partner with healthcare organizations to address these consumers' nutritional needs. And it's the consumers in your most vulnerable populations. And then they provide this platform they call the BBC Health and Nutrition Platform that facilitates and optimizes this personalized, culturally concordant food program, in addition to other tools to drive lasting behavioral change and technology. And the technology they have allows you to do it at scale. So beyond all that, they also help engage members and your patients to support that whole health and lifestyle modification through omnichannel wraparound support and education. And this enables the individuals you're helping support make informed choices and gain a much deeper understanding of the impact of their diet and their lifestyle and their overall well-being, empowering them to be better off in the long term for a happier and healthier life. So I see them as being a really interesting, well-suited organization to help all of us think about what kind of companion alternative solutions we want to provide members who are focusing on weight loss, especially your members who may be on GLP-1s and other anti-obesity medication therapy. So you can check them out at nourishedrx.com. If you just want to pick Lauren and her team's brains, I'm telling you, someone like issued that case study out earlier. And if you were here late and you wanted a copy of that, just hit us up in the chat. They're a wealth of information. You don't need to hire them to get a little bit of the tap into their knowledge. Let me know. In fact, why don't, Gene, we put up something. They want an introduction, a personal introduction from Eric to Lauren. I'll be happy to do that for everyone after the show. So it's a warm introduction, warm transfer. All right, let's get into benefit design right now. Angie, I know we're running a little bit late on time. I'm behind. How is BSC thinking about medication for those living with diabetes and obesity, these GLP-1s, and how are you designing your benefits now to support that while also maintaining sort of a healthy business?
Yeah, absolutely. And a healthy business is a consideration, certainly for payers. These drugs are not inexpensive, although, as you said, Tim, neither are the conditions. So we have to do it in the right way. The way we're approaching it at Blue Shield of California is that Ozempic is covered for members that have type 2 diabetes. So if a member that has type 2 diabetes applies for that GLP-1, they will be approved for the medication. However, for members that are applying for the GLP-1 brand Wegovy, I guess that is not covered. And it requires members to go through what we're calling step therapy in order to become approved for that drug. So, and I can probably explain this in a really good way if I just kind of take you through a member journey of what it would look like for like Jane Smith. Okay, Jane Smith comes to her doctor and wants to try a GLP-1 to help address her obesity condition. When that is submitted to Blue Shield, she will get a letter from Blue Shield that says, in order to be approved for this drug, you need to complete 6 months of a weight management program. The letter will refer her to Wellvolution so she can go herself, and our partners at Wellvolution will reach out to Jane Smith as well, letting her know that this is available to her. Once she registers for the platform on Wellvolution, she'll go through that question set that I described earlier, where she's going to be matched with a program that's really, really going to work for her, and is going to be paired with a health coach that will work with her on a day-to-day basis. So, and some of the things that come along with the program are a weight scale, in some cases, a glucometer or a ketone measurement device. You'll get a Fitbit. So again, you start to get all the tools that you need to support the habit building. Jane will be required to weigh herself on a regular basis, maybe take pictures of her food, log her protein intake. It just sort of depends on the program that she's chosen, but there are different metrics that they are trying to hit every day. And the health coach will be keeping her on track in doing this. So this goes along for 6 months. And in those 6 months, Jane has established habits and a lifestyle that now, when she goes on to the GLP-1, if she decides that she wants to, because maybe at that point, she's already lost a bunch of weight, she feels great, she's achieved a lot of her goals. And maybe she doesn't feel like taking a medication every day. So she may decide not to go on the GLP-1 drug, or any weight management drug for that matter. Or she may decide she wants to continue. She hasn't reached her goals yet. Then she can go on the drug, but have the right support to continue the weight loss and sustain it once she's hit her goal. So I think that sort of is a really kind of good end-to-end approach of how we are looking at using medications.
I like that. Let's do this, because I know we're getting at 13 minutes left. So here's what we're going to run the rest of the hour here, folks. I want to have Lauren come in and tell a story too, because I think she's got a really cool consumer story with someone that we call Marianne that I'd like everyone to hear. Then I'd like Tim to talk about how he would, or how Highmark is integrating mental health into the support of individuals. And then we're going to close out with a great story about the state of Connecticut and all their employees with Katherine. I think that's how we'll close out the last 13 minutes. And incidentally, our first episode of next year, everyone, is going to be on GLP-1s and musculoskeletal, and how that plays into, obesity, MSK, and GLP-1. So if you want us to pre-register for you, that Jean, while everyone's talking, is going to put up a form, and we'll register you for that ahead of time as you get ready for next year. So why don't we start with you, Lauren, and let's hear a little bit of another story, a member story, on how an individual brings in nutrition for behavioral change.
Yeah, sure. Thanks, Eric. And this example actually gives me an opportunity to shine a spotlight on what I think is kind of the biggest problem within the problem. And that really is for people who are have obesity, other diet-related disease, and they're also food insecure and or nutrition insecure. And this is a huge swath of the population. I mean, depending on the state, it can be anywhere from 10 to 24% of the members are at risk of food insecurity. And why that's so relevant is what I was talking about earlier, just that people get nostalgically attached, so it's that much harder to change diet if that's all they've eaten their entire life. And so if you are food or nutrition insecure, it's likely that you've only had exposure to unhealthy food. And so Marianne's a perfect example of this. She's 54 years old, lives in Indianapolis. She was diagnosed with type 2 uncontrolled diabetes and obesity, and was also at risk of food insecurity. And at the get-go, through our intake survey and a PHQ-2 screen, we recognized she was at risk of depression. So we were able to refer her to a health plan's behavioral health case management program. And we learned that her grandson, this was, gosh, I'm forgetting who made the point that you really have to understand the individual's motivation. But she talked about her grandson and explained to us that she realized that if she could get her A1C down, that she could potentially extend her life. And she thought about that in terms of the age of her grandson. She might be able to live until he's 10 years old. And so our RD was able to really engage in this motivation very effectively. And because she had really only been eating fast prepared meals, like, McDonald's hamburgers, it was really important that we start her out with prepared meals that were healthy, not still chicken, not 100% vegan or something, but more vegetables, and then transition her to groceries. And she had a really hard time transitioning to groceries because she had not been in a position of preparing food for quite a long time. And so the support to be able to support her, I've never seen a cauliflower type thing. What do I do with this? So the support there was absolutely critical. And because of, her circumstances, having never been exposed to healthy food, which is just a broader problem that I think we all recognize, at the outset, her results were extraordinary. So her A1C dropped from 11.5 to 6.8, and this was in 14 weeks. She was taken off an oral anti-diabetic medication. Her weight dropped from basically 230 to 180, and she enrolled in SNAP. And one of her final comments to us was she couldn't wait to work with her daughter to help transform her daughter and her grandson's diets as well. So that's my member story.
Love it. What about mental health now here, Tim? We haven't really hit on it head on. Talk to me about how Highmark's kind of thinking about collaborative care.
Yeah, so I mean, as someone asked in the chat about what we're looking at for the next year, one of the things we're looking at is some of the digital therapeutics which incorporate mental health into it. We think that, as well as I'm sure others on the panel here think that, peer-to-peer mentoring in this space is so hugely purposeful to help people on their journey to this new lifestyle that we need them to approach. And so to do it in a vacuum with nothing more than, say, a coach to interact with on an app, while that may be beneficial to some, it's not enough. And so we're not trying to get someone through the next 6 weeks to lose 5 pounds to do an Instagram shoot on the beach. We're trying to get someone to live a healthier life for life. And so sometimes in order to do that, you need to be able to bounce, the good, the bad, and the ugly off of each other in an honest and real way, not too unlike Narcotics or Alcoholics Anonymous in a way. And that is, you have a true, honest, friend or so, or at least an honest acquaintance that can understand what you're going through and allow you to open up and give your both good, the bad, and the ugly of what's going on with you. So I think the peer-to-peer part of it is really where we're focused on this coming year.
Yeah, I really like that. Incidentally, first of all, folks, you saw in the chat, I just sent you all an email to ask you for feedback for not only today's session, but also topics for next year. So please take a couple of minutes to fill it out. One of the things I asked you about, and maybe Gene, we could do a quick poll here since I have everyone, is we're going to start a couple of private leadership councils next year. The first one we're going to do is focused on Medicare and Medicaid and how to think about navigation to benefits and what solutions are out there and what organizations are doing to truly help these harder to reach individuals get to the right place at the right point of time. And the goal is to have 6 to 8 health plans on this council with maybe 1 or 2 innovators and have quarterly meetings about it. So if you're interested in joining those, just getting more information about them, let Gene know through this poll and we'll get in touch with you. So Katherine, I want to now get this example around the state of Connecticut and how you've helped build what a program looks like with personalized approach to lifestyle modification and treatments and medication treatments and how that looks and feels.
Yeah, so I'll try to be really brief. So the state of Connecticut, just like many other employers and states, was faced with the really difficult challenge of, their employees really, really, really wanting access to medical obesity treatment, but looking at the numbers, being concerned that they could literally go bankrupt as a state. And I think many employers are grappling with this right now, and they think that there are two options, either saying no, kind of kicking the can, not doing anything, or opening up the floodgates to appropriate, inappropriate, just indiscriminate GLP-1 prescribing, which leads to overspending. And then, as we've seen with other states and other employers, potentially rescinding coverage, which is not a good situation. So the state of Connecticut has been very thoughtful about how they want to approach this. They felt strongly about being able to provide access to care for their employees, but with guardrails. So they know it's not going to be inexpensive, but they don't want to massively overspend and not know who's being prescribed what with what kind of education and support. So they came to us, and the phase one of our program with the state of Connecticut is that we have an exclusive arrangement where if any of their employees want access to medications like GLP-1s or any of the other anti-obesity medications, that they come through us, so our telemedicine practice, Flight Medical, to get all of the medical care. And they trust that we are prescribing in a way that is very reasonable, that's very comprehensive, that's really setting patients up for success in a cost-effective way. So we certainly use GLP-1s, but in a much smaller percentage than, many of the solutions out there. And so this is the phase one of our program. And then phase two, we're rolling it out to providers throughout the state of Connecticut. But I can tell, it's only been a couple of months. We're seeing great numbers so far, but it's still a little bit early to be looking at, weight data and health outcome data. But just qualitatively, the kind of care that we've been taking over, a lot of compounded medication, a lot of prescribing to patients who aren't great candidates, a lot of prescribing without any education or support. So a lot of side effects, a lot of, things that we're hearing about in the media that shouldn't be happening as much if these medications were prescribed by providers who, really understand obesity medicine and understand how to prescribe in a really tailored way as part of the comprehensive program that we're talking about. So the point of this is that there are solutions that aren't just saying no or opening the floodgates to robo-prescribing GLP-1s. And this is what we're proving. So, we think that this model with the state of Connecticut is a model that other states can employ and other employers can employ. And we've had a lot of recognition for this and a lot of conversations with other states and many employers and, partnerships and everything, because this is a way to do it and get really good outcomes in a more cost-effective way.
Great stuff. Couple of minutes left. Tim, are you okay if I bring in that value creation chain question to you to end things here?
Oh, sure. I was actually typing a response to it now.
Okay, well, I'll save you some time. So I'll ask, so everyone here, if you think value-based care as a value creation chain, if you think about it, with many steps, whether that be from an engagement to enrollment to ongoing nudges and everything in between, are you breaking down those different steps? Are you measuring those, and how are you approaching that? And if we have time, have you
Yep. So just briefly, we're looking at next comes instead of outcomes. So the outcome is at the very end of that chain of all those things you mentioned, from engagement to, retention, et cetera. But we're looking at each step along there as we move towards more of a risk-based environment for providers. They're leaning on the plans ourselves specifically to tell them what each stage of those has done. So engagement, what does that get us? Well, that gets us to the next come, which is, to continue the continuation of the program and so on. And so if you just try to look at the beginning and the end, you've missed a whole lot of stuff in the middle. And sometimes it's okay just to get to the middle and restart again, because these journeys that people are doing for lifestyle modification don't always happen from A to Z. They sometimes go from A to C and back to A again before they get to E and F. So we have to make sure that, I think it was Katherine said earlier, about it's an individual approach to each individual. That's, individuals are individuals. And so we have to take the same approach in the value-based care part of it as well. And that's why we're looking at what I call next comes instead of outcomes.
Angie, do you have anything to add or to that?
Yeah, I mean, actually, the way that we have designed our payment models are milestone based. So we very similarly look at, we pay our providers based on enrollment, 30-day engagement, 90-day engagement, 5% weight loss, maintenance of the weight loss. So there's sort of a continuum over time that we go through. So yes, 100% agree.
I want to thank the four of you. You were incredible, and the work you took, the work and time you put in to prepare with me for all this. I really do appreciate it, and thank you to our partner today, NourishedRX. To everyone watching and listening, thank you. The hour that you take during your day to consume a show like this isn't lost on me. That is an hour that there's 100 other things you should be doing or could be doing with that. So thank you for trusting us with your time. We hope you use the bright spots shared today to inspire your thinking and enhance your organization's current approach to improving healthcare for all of us. Have a very good rest of your day, everyone. This has been your Bright Spots in Healthcare podcast.